Occasionally, you might be called upon to use what's known as the ZTrack method for IM injections. You won't have to give this as often. It's discussed on page 51 in your book, and it is for drugs that are going to stain the skin or could be irritating to tissues. In this case, you're not going to firm the tissue by squeezing it. Instead, you're going to take your fingers and you're going to pull the skin layers to the side about an inch. What that does is it causes a separation of the skin layers once it pops back. So you pull, as you can see, pulling with your forefinger, and then you administer the IM injection. You will aspirate to make sure that you're not in a vein, but you will not massage afterwards. You want to go deep IM. Now, examples of drugs that could be irritating to tissues are medications like hydroxyzine, that's given sometimes as a pre-op shot. I've had that once, and I swear it still stings, and I was 15 years old at the time. Awful medication. You want to give it deep. You want to go ZTrack. It used to be that a lot of iron injections were given in the skin for somebody who was anemic, and that medication could come up and it would stain the area of the skin where the injection had been given. So you can see when you let go that you've got the pool of medication, but then it branches off into different areas of the skin, and it's not going to bleed up to the surface and irritate the skin, cause it to necrose, or turn it a different color. All right, so that's it for basic information about injections. Like I said, injection lab will cover that a little bit more hands-on. Plus, hopefully you'll have various situations where you can give different kinds of injections in your clinical settings. We're going to talk a little bit about IV technique. Now, once you graduate and you are either getting ready to take your boards or you've already taken your boards and you're working, you can take an IV certification class. This is for people who've already graduated, and you can get a certificate of IV training. You might work in a facility that provides the training, or TCAT will usually do 2 or 3 IV certification classes a year that you can take advantage of. Now, in these classes, you might learn about adding medication by syringe to an infusion, which is IV push. A lot of facilities won't allow LPNs to give IV push, but the Nurse Practice Act of Tennessee does allow for you to be able to do it in certain circumstances. Some places just won't, have you do it, period. You might learn about adding medication to a plastic bag or an IV bottle, although more and more pharmacies are mixing their own meds to cut down on drug errors. Adding medication to a volume control, so a pump of some type. Adding medication by piggyback, where you are hanging a small bag and putting it in the port of a larger bag. Or administration of medication when there's just an intermittent infusion device. Many times these are nicknamed INTs, and it's a way to have IV access without having a running IV. So you'll talk about those in your IV certification class. We've already done math. We've talked about monitoring infusion rates. You've learned how to calculate infusion rates. There are going to be various pumps that you work with. We'll get to work a little bit with pumps in IV, in MedPass clinical. But there are lots of different kinds of pumps, and every place you work will have different pumps. There are implantable pumps that can be planted under the skin, like insulin pumps and other kinds of medications that are either go sub-Q and the pump is on the outside, or sometimes there's an implanted pump on the inside of the skin. Remember that IV drugs go straight into the bloodstream. Unlike all the other injections where the medication is put into some part of the skin and then slowly or quickly absorbs depending on the type of the types of ingredients that are added with the injections. IV drugs go straight into the bloodstream. And so once you've injected something, it's in there. You can't get it back. So you want to check all your medications at least 3 times. You know, doesn't hurt to check more, but especially make sure that you are monitoring something going straight into the bloodstream, because you can't bring it back. Read your textbook pages 51 through 54. Some of it is a kind of a recap of what you've already learned in math about calculating infusion rates, so just skim over that part. But read all the memory joggers, read the safety tips. The only thing we're going to really cover in this chapter is common problems with intravenous infusions. This is listed on page 55. You will see many times as an LPN that a patient has an IV and they call out for help, and you're the one who ends up going in there. And so sometimes it's things that you can address. Excuse me. If the, I'm sorry, back and forth, you guys are going to get seasick. I have this slide that is about troubleshooting IVs. Troubleshooting means, what's the problem? Why is this not working? Sometimes it can be caused by a failure to infuse properly. Is the pump beeping? It might be because of bent tubing. The needle or the little plastic Cathlon might be against the vein wall, and you just have to check the position. If you have a very short pole, the pump has to push against gravity and it's going to beep. Is the IV site infiltrated? And we'll talk about that in a minute. There might be a little clot in the needle, and you can just flush it with normal saline, just a real tiny little obstruction. Or there could be kinks in the IV tubing. Sometimes you'll get an uncomfortable patient or an elderly patient who's a little confused, and you go in and they are wrapped up in their tubing like a spider has wound them into a web, and you have to get them untangled. Those are things you want to look for. Now, if the IV site is infiltrated, you got a whole other thing going on. You can't continue to put medications into an infiltrated IV, because infiltration means the vein is leaking, and so all that medication is going into the tissue around the site. Veins aren't like, you know, a brand new garden hose where it's, you know, all nice and rubbery and springy and nothing comes out. Veins are somewhat permeable, and things can leak out if an area of the vein is irritated. This will introduce fluid into the tissues, and sometimes when a person's complaining of a painful IV, an IV that stings, you don't really know if you're dealing with infiltration, which is leaking of fluid, or an infection. Any IV that's having problems is going to be, these are what you're going to look for: swelling, pain, and erythema, or redness. Swelling, pain, and redness. Any of those indicate you got a problem with the IV. Now, the difference is when you touch the site, is it cold or is it warm? Fluids building up at the site are going to make that skin cold. Many times infection, because white blood cells are rushing to that site to try to clean up those bacteria, it's going to be warm to the touch. Now, when you have a suspected infiltration, these are the steps, and you need to present them in this order, the order they are in the PowerPoint. When you see infiltration, you'll see the steps to taking care of the problem. You don't want to use the order in that table. You want to use the order in the reading or in this PowerPoint. Ignore the table, they mix it up. But these are what you'd have to list in a test or quiz. Hint, hint, hint. Step 1 is inspect for injury. Now somebody says, well, why don't you stop the infusion? Because you want to look and see what you're dealing with first. You know, you don't necessarily want to stop it if it's just uncomfortable. Some people will complain about an uncomfortable IV, even though it's not infiltrated or there's no problem. It's just hurting them. It is uncomfortable. You've got a plastic thing in your vein and there's fluid going in it. So look at it first. So you're inspecting, you're looking, you're seeing, do I have swelling? Do I have pain? Do I have redness? That indicates a problem. Is it cold to the touch or warm to the touch? Then, after you've looked at it, then you stop the infusion. You don't have to DC the IV, just stop the fluid from going in. You're just throwing, good medicine after bad. You want to notify the physician, and you can apply a warm, moist compress, meaning you can take a washcloth, run it under warm water, squeeze it out and put it on the sore spot. Don't go microwave something. You could burn somebody in addition to them having an infiltrated vein. Just a warm, moist compress. If you are working under the guidance of an RN, they might tell you DC the IV or they'll come do it themselves. If not, if you're on your own doing an IV, that's when you notify the physician and don't pull the IV till they tell you to. So you want to use this order: inspect for injury, stop infusion, notify physician or other healthcare provider, and then warm, moist compresses to that particular area. Other IV problems are listed on page 55. Make sure you read those carefully. Air in the tubing, circulatory problems can be emergent, and the reading tells you what to do. You want to always take seriously anybody complaining about their IV. If you suspect an allergic reaction, and in that case you'll see widespread rash, itching, difficulty breathing, shortness of breath that you can hear, or difficulty breathing that you can hear, stop that infusion immediately. It might turn out not to be an allergy, but you always want to make sure. Stop that infusion.